Looks like we have a pretty good crowd here today, so that's exciting. Welcome to the webinar. Okay, now the objectives for today's presentation: to discuss the various types of acquired brain injuries. And then towards the end of our presentation, we will do some brief training on the Ohio State University TBI screening measure, which is a well-validated measure for identifying individuals who have experienced a TBI. Here at RHI, we've added some additional items that also help and will help hopefully you guys screen for acquired brain injuries that are that are not TBI. And then we will wrap up by giving 2 examples from our resource facilitation cases as to how to utilize the screening measure. Some of this may look familiar. If anybody, we just released our Working Brain newsletter, and so we addressed this idea of the umbrella of acquired brain injury in that edition of the Working Brain. So some of this might look slightly familiar here at the beginning. And part of the attempt at this is just to elucidate the idea that brain injury is beyond TBI. That has gotten a lot of attention in the media, of course, over the past several years. Traumatic brain injury with the wars and even in football and that sort of thing. But we think of brain injury as much broader than just traumatic brain injury. And so we use the term acquired brain injury. It's an umbrella term. With the brain being the most complex organ of the body, injury to it can lead to a vast array of consequences, and therefore we can't always assume, that just because you could theoretically say that 2 individuals had the same injury, that it will affect them similarly. It's unique for each person. And sometimes it's easier to comprehend how maybe an individual could have a head injury from a fall or a motor vehicle accident or sports injury, and less obvious or understood from other mechanisms of injury. So the umbrella term, acquired brain injury, is used to encompass all brain injuries that occur after birth and are non-progressive in nature. Each of these types of brain injuries can have lasting physical, cognitive, behavioral, emotional, social, and vocational effects. The research on our resource facilitation program included people with ABI, not just TBI, and therefore best practices for the vocational rehabilitation of people with ABI is felt to be resource facilitation, and certainly several of the individuals who participated in our studies had brain injuries that were not TBIs. Okay. When we talk about ABI, we can break it down into 2 categories, that is traumatic and non-traumatic. We're going to talk about each of these individually, so I won't necessarily list them off here, and we'll start by talking about traumatic brain injuries. In the most briefest definition, a TBI occurs when an external mechanical force causes brain dysfunction. So that's a very brief definition, but also somewhat vague. A little more specific is the second definition. Brain or traumatic brain injury is a non-degenerative, non-congenital, so it doesn't happen at birth and it doesn't progress, insult to the brain from an external mechanical force, possibly leading to permanent or temporary impairment of cognitive, physical, and psychosocial functions, with an associated diminished or altered state of consciousness. Okay. The most common mechanisms for traumatic brain injury include these 2 mechanisms here. That's a coup, contra-coup injury, and then the diffuse axonal injury. With respect to a coup injury, that occurs under the site of impact with an object. A contra-coup injury occurs on the side opposite the area that was impacted. So you see the picture on your screen, the object being a baseball coming at the head. The coup is where the initial impact occurs, and then on the opposite side of the brain, it hits against the skull, and that is considered the counter or the contra-coup. When a moving object impacts a stationary head, coup injuries are typical, while a contra-coup injury is more typical when the moving head hits a stationary object. So a fall would be a good example of a contra-coup injury, or the greater likelihood that you're going to have a contra-coup occur. Cerebral contusions is just the fancy word for bruising, tend to occur at the tips of the frontal and temporal lobes, where they bang up against the interior of the skull. So down in the picture below, that's an inside of the skull. So, the outside of our skull is fairly smooth, not too bumpy. That's not the case for the inside of our skull, and where the deepest kind of grooves or ridges tend to be at the tips of our frontal and temporal lobes. And so a lot of contusion, bleeding, bruising can occur in those areas. Now moving on to diffuse axonal injury. This refers to damage that occurs over a more widespread area as compared to a focal brain injury. So DAI is the result of traumatic shearing forces that occur when the head is rapidly accelerated or decelerated, and may occur as the result of automobile accidents, falls, assaults, any time where there's kind of a shaking of the head, in which case the brain is able to move within the skull back and forth. The shearing and tearing and stretching of axons occurs particularly at the white matter tracts. So on your screen here, it's showing on the far right side, those are axons, the little blue, I don't know what we call those, but the blue little line things are supposed to represent axons, and actually made up of white matter. And those are the things that are getting torn, twisted, sheared. They help produce the electrical impulse that essentially helps one area of the brain communicate with another area of the brain and produce the output. When they're damaged in any way, you can get a change in the function of the cognition or behavior. You'll see on your screen that it says the injury is greatest where the density difference is greatest. So there's a density difference in the brain between what they call gray matter, which is more on the outer portion of the brain, and then the white matter, which is on the inner portion. So there's a density there, and in physics affects it differently with the impact, and then the shearing and tearing occurs mostly at those junctures. Damage can be microscopic, and often is, and therefore doesn't always show up on neuroimaging. And it's very common for someone who might have been in an automobile accident, where they can see very easily on MRI or CT scan an area of bleeding or contusion, but then also based on the mechanism of the injury, that is an acceleration-deceleration injury, we also assume there's diffuse axonal injury in this case, even if it's not showing up on the MRI. Okay. Very briefly, I'll cover kind of how the grading or severity of TBI is determined. There's multiple factors. Those are listed there on the left. So they're looking at neuroimaging, length of loss of consciousness, whether or not there was an alteration of consciousness, post-traumatic amnesia, and Glasgow Coma Scale scores that are taken at the time of the injury. And you'll see that for the mild TBI category, oftentimes that imaging is normal. The loss of consciousness is somewhere between 0 and 30 minutes. There is usually some alteration of consciousness, but it may only be for a moment, but could last up to 24 hours. Length of post-traumatic amnesia, there may or may not be post-traumatic amnesia, but it shouldn't be more than a day. And then a GCS score of somewhere between 13 and 15. 15 essentially is a normal score for the Glasgow Coma score. The lower the score, the worse the injury is. On the moderate side, you still may have normal imaging, but you may also have some abnormal findings. The loss of consciousness now needs to be greater than 30 minutes, but less than 24 hours. The alteration of consciousness, which can just be a complaint of, well, I felt dazed or I felt confused. I didn't quite know what was going on. I remember bits and pieces, kind of thing, which then starts to go into the post-traumatic amnesia. But for the alteration of consciousness at the moderate level, greater than 24 hours. PTA, greater than 1 day, but less than 7 days, and GCS is a 9 to 12 score. The severe, more commonly, you are going to see neuroimaging findings, but they do suggest that sometimes there may be an absence of neuroimaging findings. The loss of consciousness greater than 24 hours. So these are your coma, people in coma at some point. Alteration of consciousness, that severity is based on other criteria. They don't put a specific on that. PTA being greater than 7 days, and then the Glasgow Coma Scale being from 3 to 8. And these are the classification systems based on the 2009 VA and Department of Defense clinical practice guidelines. This next slide here is kind of a breakdown of the percentage of cases of traumatic brain injury, and we know that there's over 1 million cases a year. That it's actually a very small percentage that end up in the mild to severe category, approximately 15%. Another 15% are mild but exhibit or complain of persisting symptoms. And then there's the 70% that are considered mild injuries that their symptoms resolve relatively quickly and don't necessarily end up going on to have rehabilitation services. The moderate to severe TBIs, it's very common for them to have more lasting effects and to have changes in multiple domains of functioning. So some basic cognitive skills may be disrupted, sustained attention, concentration, remembering new information. People will call that short-term memory. Processing of information is usually slowed, and then solving problems and making decisions they have difficulty with. Neurobehavioral changes are common as well. You'll see things like decreased inhibition and increased impulsivity. Difficulty with initiating tasks, maintaining tasks, following through, diminished awareness of what their weaknesses are or that they're having difficulties, and then some social inappropriateness can happen. Possible emotional and social consequences might include increased irritability and aggression, depression, anxiety, mood lability, social withdrawal. And then, of course, in some other domains, physical, as well as any other medical complications that could be related to the TBI. You can get hormonal changes, metabolic changes. So it really, the list is very extensive, and this is just kind of a very brief overview. How would some of these play out on a more functional level? So for example, someone with an attention deficit on the job or in the classroom is likely to have difficulty focusing on or responding to the required tasks or directions. Going to become easily distracted by any little stimuli that's going on in the environment. As far as memory deficits, they're going to have difficulty understanding and learning new information primarily. Memory for information that is kind of rote and that they have a lot of history with prior to their injury tends to be a little more hardy and resistant to injury, and so those long-term memories are less disrupted typically, although they can be. Irritability or anger, these individuals are likely to have the potential for having incidents with coworkers, supervisors. Their behavior then might become more of a focus on how are we going to help them be most successful on the job. Similarly, if they are uninhibited or they exhibit impulsive behavior, that may lead them to have poor inhibition of emotions or desires. They may be on the job making inappropriate jokes, using drugs that, of course, then when they're screened, if they have a job that they are getting drug testing, that sort of thing can definitely be problematic, and how it affects their performance, obviously, on the job. And then rage would be another example. As far as executive functions deficits, that might look something like having difficulty organizing behavior to get to the point where they're able to execute their stated intentions or goals. So they may be able to tell you exactly what they need to do. They may seem as though they fully understand what their directions are and what their plan is as to how to perform a task. And when it comes down to it, they have a difficult time executing that due to an executive function difficulty. Okay. I'm going to spend a few slides talking about mild TBI for a minute because sometimes I feel like that's a little less understood, and because the term mild TBI is interchanged with concussion, at times can also be more minimized, I feel. People think of, and particularly in the past, it's a little less so now with all the press it's getting, but used to be in the past that people thought of a concussion as just, they got knocked on the head, they're fine. Maybe they have a headache, they take some Advil, that goes away the next day, and they just go on with their business. Now we do tend to think of concussion as a mild TBI, and essentially, based on the criteria from the American Congress of Rehabilitation Medicine, they define a mild TBI as a traumatically induced physiological disruption of brain function as manifested by at least one of the following: any loss of consciousness, any loss of memory before or after injury. And it's important to note that usually people will describe that as fuzzy memories, or I remember bits and pieces. Alteration of mental state. So some people will say, I just didn't feel right. I felt confused. I felt a little dazed. Things seemed surreal. Focal neurologic deficit that may or may not be transient. And severity of the injury does not exceed the following. So again, they can't have a loss of consciousness greater than 30 minutes. After 30 minutes, an initial Glasgow coma score of 13 to 15. So it can't be lower than that. And their PTA has to be less than or equal to 24 hours. I think the big point here is to is the loss of consciousness. I think a lot of people have heard or make an assumption that concussion equals a loss of consciousness, and that is not always the case. And so to not assume that someone didn't have a concussion just because they don't think they lost consciousness doesn't rule them out. Okay. In concussion, there can be a lot of acute symptoms that the individual is complaining of. again, if we put them into domain categories, in the physical category, headaches, nausea, vomiting, blurred or double vision, seeing stars or lights, dizziness, sensitivity to light or noise, and tinnitus or ringing in the ears are common complaints. In the behavioral emotional category, things like drowsiness, fatigue and lethargy, irritability, anxiety, depression, changes in sleeping patterns and changes can also be an appetite too, but in terms of the sleeping, a lot of times it'll be more of an insomnia kind of nature where they'll have difficulty initiating or falling asleep. In the cognitive category, they might describe it as just feeling slow. I just can't think as quickly as I used to. Or again, they'll use terms like I feel dazed or like my head is in a fog. I've had someone recently who described it as feeling like their head was disconnected from their body. Interesting way to describe it. Difficulty concentrating, difficulty remembering, feeling more forgetful. So those are all symptoms that people can be complaining of as soon as within a few hours of the injury, but then sometimes some of these don't emerge until a couple days later, and maybe up to a week later where they start to really either become aware or begin to experience some of these symptoms, post-concussion or mild TBI. Then we have the diagnosis of post-concussive syndrome. Here, the ICD-10 defines it as a history of head trauma with loss of consciousness preceding symptom onset by a maximum of 4 weeks. So you can't assume that someone who had a concussion 6 months ago and is now just saying, I developed these symptoms within the last week. We're not going to call that post-concussive syndrome because we can't link that to the actual head trauma. So the symptoms have to emerge within 4 weeks in order to be considered possibly related. Symptoms in 3 or more of the following categories, so headache, dizziness, malaise, fatigue, noise intolerance, the irritability, depression, anxiety, emotional lability, subjective concentration, memory, or intellectual difficulties without the support of neurological evidence or marked impairment. I'm going to stop there. That one's really important because what that's saying is even if on neuropsychological testing, they essentially, it does not show impairment levels in those areas, does not mean that they don't qualify for a diagnosis of post-concussive disorder. They just have to perceive the difficulties in those areas. Insomnia, reduced alcohol tolerance, and preoccupation with symptoms. So I think of that as like just becoming kind of hypersensitive to or hyper alert to the experience of any of these symptoms. Some people would describe it, and here it says it as like a hypochondriacal concern and possible adoption of the sick role. Again, you don't have to have neuroimaging findings in order to have this diagnosis. When it comes to discussing post-concussive syndrome, in the literature and then even in conferences that we attend on brain injury now, it's still a heavily debated topic. The diagnostic criteria widely varies. They say that symptoms have to appear within 1 week, whereas I just read to you that symptoms have to appear within 4 weeks. Other people will say that, well, you can't really diagnose it until the symptoms have been present for at least 3 months. So very wide-ranging. Symptoms typically will resolve post-concussion within 3 to 6 months. The vast majority of individuals will have full symptom resolution within that time. However, roughly 10 to 20% have continued symptoms. They're now starting to talk about what has been termed a persistent post-concussive syndrome. That would be symptoms lasting longer than that 3 to 6 month mark. And then now, even beyond persistent, they're saying, is there anything such as a permanent post-concussive syndrome? There was a study, a small study of 24 individuals who were reporting continuing to experience post-concussive symptoms, the average being approximately 6.9 years post-injury. They found that all of those participants endorsed fatigue. So that was their number one symptom. Other frequently endorsed symptoms included continued issues with concentration, sleep disturbances, slowed processing speed, and irritability. So I can't tell you for sure, that really, does or doesn't exist, certainly, but there is some suggestion of that in my clinical experiences that I do believe that's possible. A little bit more on persistent post-concussive syndrome. You see at the top here, it's been referred to as the miserable minority. You can imagine why. That unfortunately they weren't in that 70% that had full symptom resolution. They had what they thought was a very minor injury. They've been told they should have had all their symptoms gone by now. Why are they still experiencing some of these symptoms? That can be very frustrating for the patient and for the family. The estimations of prevalence vary widely. So anywhere from less than 5% endorsing symptoms at 6 to 12 months. Then you see 7 to 15% are endorsing symptoms 1 year post-injury, and then 10 to 20 having persistent symptoms at 6 to 12 months and beyond. So roughly, very, very, very rough estimates of the prevalence of persistent post-concussive syndrome being somewhere around 27 and 100,000, which I thought was interestingly that it's equal to the annual incidence of Parkinson's, multiple sclerosis, Guillain-Barré, motor neuron disease such as ALS, and myasthenia gravis combined. So that kind of puts it in a little bit of perspective. It's more common than we, I think, acknowledge sometimes. Okay, moving beyond mild TBI and just talking about when a TBI occurs in the brain, there's the initial injury, and then there's secondary post-traumatic injury. And essentially what happens is the initial injury is setting in motion molecular and hormonal changes in the brain. These changes, chemical reactions, can be destructive to the brain, and unfortunately, they can occur up to weeks and sometimes years post-injury. And we don't have a good way, we don't understand it completely, the processes that are happening, and we also don't have a great way of predicting, in whose brain will this continue to happen and for how long. The bottom line is that people can and sometimes do get worse in the short run with brain injury. And sometimes the secondary post-traumatic injury is actually the bigger concern than was the initial injury. So they might be well aware that there was some small bleed, that there was some contusions in the brain. The person's in ICU for monitoring, and they start to notice increased swelling, which is considered a secondary impact, or impact's probably not the right term, but a secondary effect of the initial injury, and that actually becomes more of a concern than the contusion or the bleeding. The swelling can be certainly lethal if they are not able to treat it properly. Another reason that people sometimes feel like they get worse as opposed to get better after injury is that as they gradually start to go back to real life, they're starting to notice some of their problems. Some of that awareness is emerging. And then again, we're not always sure for which patients it's occurring that some of these continued chemical reactions are happening and cells continue to die in the brain, even several months and years post-injury. Okay, so that was my very brief overview of traumatic brain injury. Now we're going to talk about non-traumatic brain injury. So this is going to include stroke, anoxic and hypoxic injuries, brain tumor, brain surgery, infection, toxic and metabolic injury, electrocution, struck by lightning, and hydrocephalus. As far as stroke is concerned, we're going to break this into kind of two categories. The first one being ischemic stroke, and by far this is the most common type of stroke. This occurs when an artery to the brain is blocked, leading to a lack of oxygen to the brain cells. If the artery remains blocked for more than a few minutes, the brain cells have the potential to start dying. The most common cause is narrowing of the arteries in the neck or head due to atherosclerosis or gradual cholesterol deposits. If the arteries become too narrow, blood cells may collect and form blood clots. These blood clots can block the artery where they are formed. So if the clot occurs where it's formed, that is called a thrombosis. If that clot dislodges and becomes trapped in an artery closer to the brain or in a higher region of the brain, that is called an embolism. Another cause of ischemic stroke is blood clots in the heart, which can occur as a result of irregular heartbeats, for example, atrial fibrillation, heart attack, or abnormalities of the heart valve. While these are the most common causes of ischemic stroke, there are many other possible causes. Examples include use of street drugs, traumatic injury to the blood vessels of the neck, or disorders of blood clotting. So, for example, we saw a patient that had been in a car accident and had hit her head, so she had a contusive injury and a contracute injury. She had likely diffuse axonal injury, but also in that accident had a dissection of her carotid artery, which then caused further ischemic stroke. So you can have multiple mechanisms of injury based on the same incident. The next type of stroke is referred to as a hemorrhagic stroke. And the hemorrhagic stroke then can occur intracerebrally, which is inside the brain, or subarachnoid, which is in the surrounding area outside of the brain tissue, but within the skull. So first we'll talk about the intracerebral hemorrhage. This occurs when a blood vessel within the brain bursts, allowing blood to leak inside the brain. So that first picture you see, you're looking at what looks like kind of a big pocket of blood that starts to fill up in the brain tissue. This leads to a sudden increase in pressure in the brain and can cause damage to brain tissue. In the sense, it kind of starts to strangulate some of the surrounding brain tissue. Most common cause is high blood pressure. That is, that the high blood pressure led to the blood vessel bursting in the first place. Other causes can include trauma, infection, tumors, blood clotting deficiencies, and abnormalities in the blood vessels to begin with. So some blood vessels, people may be born with kind of a malformation. They're called arterial venous malformations that predispose that individuals to weaker blood vessels in certain areas of the brain, and therefore are more likely to rupture. Then we have the subarachnoid hemorrhage, which again is a result of bleeding, but the bleeding is occurring around and in the little sulci of the brain, not specifically in the brain tissue. This occurs when a blood vessel that's just outside the brain ruptures. The area of the skull surrounding the brain, or the arachnoid space, rapidly fills with blood. The patient with this subarachnoid hemorrhage may have a sudden intense headache, neck pain, and nausea or vomiting. It is very common for the person to say they knew something was wrong because they felt like they were having the worst headache of their life. It's intense, it's acute, it happens very quickly. It's most commonly caused by abnormalities of the arteries at the base of the brain called cerebral aneurysms. An aneurysm is a small area of rounded or irregular swelling in the arteries kind of looks like a balloon, like a little portion of it kind of balloons out, just like a balloon does. If you put too much pressure or air in it and it can't hold it anymore, it's going to burst. That's essentially what happens when an aneurysm ruptures and therefore causes the hemorrhage or the subarachnoid hemorrhage. When an aneurysm is found in the brain but remains intact, that is, it hasn't ruptured yet, that in and of itself does not represent a stroke. The stroke occurs when the aneurysm ruptures. The cause of cerebral aneurysms is not known. Some people are born with them and or develop them in childhood. They can grow very slow. Sometimes the treatment is to just watch them. It all depends on the area of the brain that they're in, how risky it would be to go in and try to do a surgical procedure called a clipping or coiling in order to get rid of the aneurysm. And then some people never know they have them until they rupture. So they can occur at any age. So sometimes we see this happens more in some of the younger folks. So sometimes even teenagers or young adults, slightly more common in women than men. We'll move on now to the anoxic hypoxic injuries. Anoxic brain injury is defined as a result of lack of oxygen, complete lack of oxygen. Hypoxic is a term used to describe low oxygen. Often, in my opinion, it's difficult to determine, is it truly an anoxic or hypoxic injury? And unfortunately, it's usually not my job to determine that. That'd be determined by the medical professionals who are treating them in the hospital, whether or not they feel like it was more anoxic or hypoxic, to know whether or not there was a complete lack of oxygen. However, what we do know is that when brain cells are without oxygen, they will begin to die in approximately 4 minutes. Causes of these types of injuries, as we know, oxygen is carried to the brain and through our bloodstream. And so therefore, you can experience anoxic brain damage if blood flow to the brain is blocked or slowed. This happens sometimes as a result of a clot, which we already kind of discussed would result in an ischemic stroke, shock, and heart problems like a heart attack. So by and large, I would say, at least as far as my clinical experience, the majority of the anoxic hypoxic injuries that I have been involved with have resulted from a heart attack. The blood flow, the second cause can be that blood flow is normal, but the blood itself is not carrying enough oxygen. And there can be a decreased amount of oxygen in the blood if the individual has a lung disease. If there's a lack of oxygen in the air, which can occur at high altitudes, you'll hear about like hiking and people that are mountain climbing and things like that can have these issues. The individual experiences prolonged exposure to certain poisons or other toxins, such as carbon monoxide, or the individual experiences an event stops them from breathing normally, such as drowning, choking, or suffocation. And I'll add to that extreme amounts of blood loss. So the blood loss could be occurring in a different area of the brain. Say they had a severe laceration in their leg, severe amounts of blood loss. They're not going to have enough oxygen and or blood to be carried to the brain. Okay. Oh, I will back up just a second. I apologize. One more thing I wanted to say about anoxic and hypoxic injury is that while anoxia, because it's kind of a generalized brain injury, it's considered diffuse. It doesn't necessarily target one area of the brain. It's not like a clot occurring in one area of the brain. It can affect all areas. However, there are certain areas of the brain, and those being the areas that use the most amount of energy, that rely the most on a very plentiful amount of oxygen, that are most susceptible to this type of injury. Those happen to be the parietal lobes and occipital lobes for our visual, spatial, and our vision abilities, the hippocampus, which is important for memory, and the basal ganglia, important in movement, and the cerebellum, important in coordination and control of movement. Those are particularly sensitive areas for an anoxic injury. Very, very, very common to have people with an anoxic injury have pretty impaired memory function. However, not always the case. Okay. As far as our next one, brain tumors, I could spend, of course, all day on talking about the different kinds of brain tumors, so I really just kind of condensed this information. If we classify them into two basic categories, you've got your primary and your secondary tumors. Primary brain tumors originate within brain tissue. Those are your astrocytomas, your oligodendrogliomas, ependymomas, meningiomas, and then there's some other less common. Your secondary are going to be caused from a cancer that originates in another part of the body. These are considered metastatic tumors. The most common places for those to originate from would be the lung, so lung cancer, melanomas, kidney cancer, breast cancer, bladder, and then there's some others that can also metastasize to the brain. Some of the primary brain tumors may be benign, therefore not cancerous or metastatic, but still require surgical resection. The changes that occur in physical, cognitive, emotional, and social functioning will depend completely on the extent and location of the tumor. So that's hard to predict until we know exactly what type of tumor, where it's at, what sort of treatment the person has. So changes can also be related to whether the person had surgical intervention, whether they had chemotherapy and or radiation. There's a growing body of literature that suggests the phenomenon, which a lot of you have probably heard of, called chemobrain, is a result from dysfunction of frontal and subcortical networks and manifest as deficits primarily in executive function, slowed processing speed, difficulties with inhibition, and goal-directed behaviors. So that being the chemo itself essentially can cause brain injury. Radiation has been found to have both immediate and delayed cognitive side effects, with whole brain radiation being a greater risk than targeted or focal radiation procedures. Finally, I'll just mention that the age at which a person had their brain tumor and received treatment does appear to be related to how long-term the cognitive difficulties are. Thus, people who have their tumor at a younger age and have the treatment that particularly can lead to some of the cognitive difficulties are more likely to have the lasting effects. That's also the case because we're talking about introducing these treatments in a developing brain. So unfortunately, the brain has not even had a chance to fully develop, and now yet you're introducing some neurotoxic chemicals or radiation. Okay. As far as brain surgery goes, that typically involves a procedure called a craniotomy. Craniotomy just refers to the operation of opening the skull. The main types of brain conditions that may require brain surgery include alterations of the brain tissue, so such as having a brain tumor, brain cancer, an infection of some sort, and or swelling. So as far as the swelling goes, sometimes, like I was back to the case where I was using earlier and said, you know, let's say someone was in a car accident, they have some bleeding and contusion in their brain, they're sent to the ICU for monitoring, and it becomes evident they're having some swelling of tissue. They have to relieve that pressure before it essentially becomes deadly. So they will intentionally take part of the skull off. They call that a bone flap. They remove that portion of the skull to allow the brain an area to swell. And when the swelling subsides and they feel like it's an appropriate time, they will eventually replace the bone flap via surgery. A second reason for having surgery might be alterations in brain blood flow, such as when they've found a subdural hematoma or pocket of blood, subarachnoid hemorrhage, and intraventricular bleed. So anytime there's a bunch of blood in there and they want to go in and take the blood out or evacuate it, they need to perform a surgical procedure. And then finally, alterations in cerebrospinal fluid, such as an infection or an hydrocephalus. They will often use what they call a shunt placement. We're going to talk about hydrocephalus in a minute, so I'll elaborate on that. Brain surgery can also sometimes be used to treat epilepsy. In terms of epilepsy surgery, you can have a bunch of different procedures. That is, one procedure might involve removing the part of the brain that's actually found to produce the seizures. Other surgeries might be intended to interrupt the nerve pathway through which the seizure impulse spreads within the brain. In other surgeries, they implant a device used to treat the epilepsy. Surgery is only considered if the area of the brain where the seizures start, called the seizure focus, can be clearly identified, and if the area can be removed is not responsible for any critical functions such as language, sensation, and movement. So a lot of times they'll go in and they will do kind of an exploratory procedure where they will open up the skull and kind of test different areas of the brain. They have some sense of where they think the seizures localizing and or generating from, and they make sure that that's not, if they were to cut in there, that's not going to be an essential function. Obviously, extensive evaluation and testing is necessary to determine if they're going to take the step of surgery. Okay. Infection. The central nervous system is vulnerable to infection, most commonly by bacteria and viruses, but can also be parasites, fungi, and other organisms. That's a little more rare. Infection leads to inflammation and swelling. I've already kind of told you about the concern there. Depending on the location of the infection, there's different names given to the infection. So meningitis being one of the most common, which is an inflammation of the meninges and the surrounding three-layered membranes of the brain, and also includes the spinal cord and the fluid that it's bathed in, or the cerebrospinal fluid. Encephalitis is an inflammation of the brain itself, the brain tissue, and an abscess is an accumulation of infectious material and offending microorganisms that can occur anywhere in the central nervous system. There's lots of effects of encephalitis. Again, we're talking about a very global type injury. It's not focal, so you can see any and all types of disturbances in function. So this picture represents, memory, physical, emotional problems. Sometimes the infection itself tends to like to settle deep in the temporal lobes. Deep in the temporal lobes is our hippocampus, our memory center. So some of these individuals, if they unfortunately have lasting effects, which is not always guaranteed, but if they do, might be prone to develop significant memory difficulties. Okay. Toxic metabolic injury. These are things that you are certainly less likely to see. I've seen maybe a couple cases in my few years as a psychologist working in brain injury, and so it's not that they don't occur. I think sometimes they're not identified because there are roughly 1,000 substances that could be possibly neurotoxic. These categories include metal, so examples would be lead and mercury. Pesticides, there's many types. Solvents and fuels, such as glues, paints, and thinners, and then carbon monoxide. Exposure to a sufficient amount of these chemicals, either in the workplace or elsewhere, can cause neurologic and brain problems. In my experience, it's been the case that people often have some inkling that this may be a possibility for them, and usually based on an environment that they've been exposed to repetitively or for a long period of time, often maybe in their work environment or something like that. As far as carbon monoxide, that does actually occur more frequently than we think it does. Survivors of carbon monoxide poisoning show decrease in mental abilities, difficulty with learning, and other neurologic damage due to the hypoxic injury that occurs because of the lack of oxygen in the blood itself. Other changes that you can see are depression, headaches, irritability. Again, these types of brain injuries caused by toxic substances are often unrecognized, and people may mistakenly attribute the symptoms to other psychiatric, metabolic, and degenerative type disorders. Okay. I'm trying to move along, recognizing the time. Okay, electrocution struck by lightning. Again, thank goodness we don't see this all too often, but people who have been exposed to high voltage electric shocks and or electric strike can have damage to the central nervous system, including the brain. Immediate effects are obvious, so they can have burns, they have cardiac arrhythmias, paresthesias, which is just weird, like physical sensations on the skin, seizures, sensory and motor deficits. The strange thing about this type of injury is that for some unknown reasons, there can be a delay in some symptom onset. And what they do think is happening is there's a it again sets in motion this progressive cellular damage that can continue to occur anywhere from days to years post-injury. The long-term effects might be more subtle and more difficult to recognize as a result of or attributable to the actual electrocution injury. But some of the neuropsychological consequences that have been identified are changes in behavior and mood, decreased attention, and verbal memory. Hydrocephalus is a result of excessive accumulation of fluid on the brain. Other people might hear it termed water on the brain. The water is the cerebral spinal fluid. In the picture you see those on the left there, the normal size ventricles. In hydrocephalus, essentially they're significantly enlarged because of the increase of the cerebral spinal fluid. I noted earlier that the most common way to treat this is to drain the cerebral spinal fluid. They implant what they call a shunt system, which you can see in the picture there, and the drain goes into the abdomen, which then is flushed out through normal body systems to keep that pressure down. People can have all kinds of, unfortunately, like complications with their shunt system. So they may have a temporary shunt to relieve pressure acutely after brain injury, or they may have a permanent shunt because of concern over recurrent hydrocephalus. And those individuals then become at risk for any complications that may also develop as a result of the shunt placement. Okay. All right, I'm going to let Devin take over at this point to begin discussing the OSU-TBI-ID. Hopefully, you guys received a copy of the PDF file of the actual measure that you can kind of refer to, but I will let her take over. Thank you.
Okay. All right. As Summer mentioned before, my name is Devin Parrott, and I'm the Clinical Research Manager and Biostatistician at the Rehab Hospital of Indiana. And I want to talk today about the Ohio State instrument for measuring traumatic brain injury, and then a few of the adjustments we made so that it can also include ABI measures, the acquired brain injury events that Summer was just describing. So the OSU-TBI-ID was published in 2007 by John Corrigan. It was designed as a structured interview for health and social service professionals, and it's used to assess TBI over the client and patient's lifetime. The measure is particularly nice because it shows strong psychometric properties, but it only takes a few minutes to administer. Recently, we added some items to the end of the actual OSU-TBI-ID, and I'll show you on the next slide where we put those and what those items are. But these allow for screening for causes of brain injury outside of the original TBI items. These additional items assess the presence of ABI history, so for example, stroke, loss of oxygen, lightning, electrocution, infection, tumor, brain injury, or brain surgery, and toxic exposure. So here's the actual form. Hopefully you guys received this. If not, we can get it out to you. But you can see there are 4 steps. The ABI items are the items that we added to the end, so that's the addition of that step 4. So overall, with the addition of the new items, there are 4 steps or components for the screening tool. However, administration should take less than 5 minutes. It can take longer for clients with many histories or history of many injuries. But keep in mind, this is a measurement tool that we are introducing to help you in assessing the presence of brain injury. This is not required for an RF referral. Okay. So the first part of the interview consists of the following 5 questions. I've circled them on this form, but it's kind of hard to see. I realize that this is small. So if you don't have the form in front of you, the next few slides I have the actual items blown up a little bit. But from this part, as you can see, the responses are all yes, no. So if a client responds no, you can simply move on to the next question. However, if they respond yes to any of the items, you'll record more information in the step 1 table, and we'll go through all of that, and we'll show you a couple of examples later to illustrate how you would move through the form. Okay. So, as I said, since the font is pretty small on the previous slide, I've copied the actual questions over the next 3 slides. Question 1 asks whether the client has ever been hospitalized or treated in an emergency room for a head or neck injury. As I said, if they respond no, you can just simply mark no and then move on to the next question. If they respond yes, then you will go to the chart and write down the cause of the injury. And then I will show you what that chart looks like after we get through these first 5 questions, all of step 1. But for example, if they said yes, you would then ask what happened. So for example, in the first question, it asks, have you ever been hospitalized or treated in an emergency room following an injury to your head or neck? So if they mark yes, then you would ask them what that injury was, and then you would record that in the step 1 chart. You'll notice that there are other options inside the step 1 chart, but we'll go through those response questions later. And then the remainder of step 1 will all follow that same format. So question 2, you'll ask again, in your lifetime, have you ever injured your head or neck in a car accident or from crashing some other moving vehicle like a bicycle, motorcycle, or ATV? If they say yes on this one, if the incident they are reporting is the same incident that you reported in question 1, you do not have to record it again. You can mark yes for both items, but when you go to the chart, you don't want to list that same cause again because there's no need to ask questions about the same injury twice. Question 3 asks whether the client has ever been injured in a fall or from being struck. It also asks about sports and playground history, playground injuries. Question 4 asks about violence, whether or not the client has been injured in a fight, shaken, or shot in the head. And question 5 asks about exposure to blasts or explosions. After step 1, the first 5 yes/no questions, you move on to step 2. If you received all no responses to step 1, you can skip step 2 and go straight to step 3. However, if you received a yes response for any of the items in step 1, you would have already recorded the cause in the step 1 table, and then step 2 just gives you some questions that you ask about that specific injury. Okay, so zooming in a little bit on step 2, you see item 6, and this item asks about whether or not the client lost consciousness, and if so, for how long. You'll record the answer in the table. If they did experience a loss of consciousness, you categorize the response in terms of the length of loss of consciousness. You can select less than 30 minutes, between 30 minutes and 1 day, or greater than 1 day. If they did not report a loss of consciousness, you will ask them if they were dazed or experienced a memory gap from the injury. Keep in mind, you do not need to ask if they reported a loss of consciousness. You do not need to ask about the memory gap. And then finally, you ask how old they were when they experienced the injury. Okay, so zooming back out and looking at the whole form, the next part is step 3. This is designed to assess a history of multiple head injuries. Similar to the previous steps, you will report the cause in the first column of the table, and then answer questions in the remainder of the table if they report any injuries. So zooming into step 3, you'll see the first question asking about multiple repeated impacts to the head. If the client responds no, you're finished with this step and you can move on to the final step 4. However, if they indicate that they have experienced multiple impacts, then similar to the previous sections, you record the cause in the step 3 table. They may have more than one cause for the multiple impacts. If they do, you can just record each cause in a new line of the table. After recording the injuries, you go back and you can ask the questions and finish the table. First, you will ask what the typical effect was. Since this injury line item consists of many different events, at first you're just trying to assess what happened most of the time. The second phase, you want to ask about the most severe effect from these injuries. And then finally, you'll ask for the age when the repeated injuries began and when they ended. So here's a closer look at the step 3 table. As you can see, the typical effect has 2 choices: dazed or memory gap with no loss of consciousness, and then also loss of consciousness. So you can mark an X if they experience loss of consciousness, or you can mark an X under dazed memory gap with no loss of consciousness if any of those were the typical effect. And then when asking about the most severe effect, you will ask the same questions, but you'll also ask about the duration of loss of consciousness using the same categories as the step 1 table. So again, they have the same options with loss of consciousness less than 30 minutes, 30 minutes to 1 day, and greater than 1 day. And then finally, you can see where you record the beginning and ending ages. So finally, you come to the final set of questions. Step 4 includes the ABI items mentioned before. This part of the interview is similar to step 1. You'll ask 7 yes/no questions, and then if you have yes for any of the questions, you record the cause and some basic information in the step 4 table. I've copied the actual questions here so you can see a close-up. Question 1 asks about stroke and ruptured aneurysms. One important thing to note with this question is that you aren't asking about an aneurysm in general, you're only asking if the aneurysm ruptured. Question 2 asks about a loss of oxygen to the brain. As you can see from the question details, many events can lead to a lack of oxygen, as Dr. Ibarra explained before. So we provided several examples to help trigger that for the client. Question 3 asks about lightning strikes. 4 asks about brain infection. And question 5 asks about brain tumors. In question 6, we cover brain surgery. And then question 7 asks about exposure to toxic materials. We've also listed some common toxic hazards to help the client remember. And then as before, if the client responded yes to any of the step 4 ABI items, you have a very similar table where you can record the cause in the step 4 table. After asking the remainder of the questions, and then you go back to get more information about any ABI incidents they reported, you can ask whether or not they received medical treatment, whether or not they were hospitalized, and the age of the injury. Okay, so that is it for completing the actual form. Scoring is also fairly simple. The scoring that we are providing you simply involves classifying the worst injury into a level of severity. And then the severity levels that we provide are improbable TBI, possible mild TBI without loss of consciousness, mild TBI with loss of consciousness, moderate TBI, and severe TBI. Okay. Now, we're going to provide 2 examples at the end to illustrate some specifics on the scoring, but here are the guidelines for those categories. To score in the improbable TBI range, the result of the questionnaire would have a no for all questions, number 1 through 5. So that's step 1, that left column, they would have all no's. And then in response to question 6, they would never report a loss of consciousness. If they did say yes and they have some events in that step 1 table, they would never report a loss of consciousness. They would never report being dazed or having memory lapses. Okay. And then to score in the next level, the possible mild TBI without loss of consciousness, you're still looking at that step 1, step 2 table, that question 6. And if in response to question 6, the interview data reports being dazed or having a memory lapse. Okay. Then the next level is mild TBI with a loss of consciousness. This, you're still looking at that same table, but this time the interview data reports a loss of consciousness, but it does not exceed 30 minutes. Okay. And just as a reminder, you are looking at the most severe injury that they reported on the step 1, step 2 table. Okay. The next level up is moderate TBI. So if in response to question 6, the report shows the loss of consciousness between 30 minutes and 24 hours. And then to score severe, you're looking at that same area. They would report a loss of consciousness for any injury exceeding 24 hours. Okay, so please note that the ABI items are not included. So that step 4 table, if you noticed, isn't even looked at during the scoring. ABI items are not typically split into levels of severity, so interpretation of the ABI items is simply whether or not the client responded yes to any of the items in step 4. Okay, so I'm going to switch back over to Summer. Dr. Ibarra is going to present some case examples, and then after each example, we'll show you an OSU rating form with the scoring.
Okay, for case number 1, we will call him Mr. Doe, 57-year-old male, status post a motor vehicle accident in 2012. He was treated at the scene but did not receive any further acute medical care. He had been working in a factory for 25 plus years. Following his accident, he went back to work within a week or so, but began having difficulties on the job. He was making errors on tasks. He was written up for these errors. He was having difficulty with balance and vision changes, but he wasn't quite sure what those were. And then his wife was noting some changes in his mood and some irritability. This continued to escalate and increase, and he was having more and more difficulty, yet he continued to go to work. And at one point, on a certain day at work, he threw hot coffee on a coworker. He was escorted out of the building, and that became the key incident, at least in the terms of him showing up in our facility and being referred to me to see what we could do to help him and what was going on. He is currently remains on long-term disability from his job due to cognitive difficulties, the vision and balance issues, and mood lability that we identified. And he has been participating in speech, vision, vestibular, balance therapy, and neuropsych rehabilitation with myself for the past year. So we're going to go through the form. We're going to do this in a way that Devin is going to ask the questions, and I'll play the role of Mr. Doe in responding.
That's going to be good. Close up so I can read it. Okay. So if you are able to look at the actual PDF file, you'll be able to see some instructions at the top and kind of some transitions between each step to kind of give you an idea of how to present the items to the client. So I'm going to try to read it straight from this form so that you have the ability to do this in the exact same way. So to start out, Mr. Doe, I'm going to ask you about injuries to your head or neck that you may have had any time in your life. Okay. Mm-hmm. In your lifetime, have you ever been hospitalized or treated in an emergency room following an injury to your head or neck? Think about any childhood injuries you remember or were told about.
No.
Okay. In your lifetime, have you ever injured your head or neck in a car accident or from crashing some other moving vehicle like a bicycle, motorcycle, or ATV?
Yes.
Okay. And can you tell me about that? What happened?
I was in a car accident in 2012.
Okay. So you can see, if you're following along, that so far on the rating form, we've marked no for item 1, and we've marked yes for item 2, and then so far at this point, we would have just marked motor vehicle accident for the cause. You don't have to ask any further questions yet until we get through this full step 1. Okay, so now we're on question 3. In your lifetime, have you ever injured your head or neck in a fall or from being hit by someone, being hit by something? For example, falling from a bike or horse, rollerblading, falling on ice, being hit by a rock. Have you ever injured your head or neck playing sports or on the playground?
No. And for the sake of time, we'll just say no to the other 2 questions.
We'll go ahead and skip the other 2, and let's just go to step 2. Okay, so Mr. Doe, you told me that you were in a motor vehicle accident. Can you tell me, were you knocked out or did you lose consciousness?
Yes. The eyewitness said I was knocked out for about 10 minutes.
Okay, so you can see where we marked less than 30 minutes. So we don't have to ask about whether or not he was dazed or if he had a gap in his memory, since he already reported a loss of consciousness. So we go straight to age. So how old were you when that happened?
57.
Okay. So now that we've finished that, we can go straight to step 3. Mr. Doe, have you ever had a period in time in which you experienced multiple repeated impacts to your head? For example, do you have a history of abuse, contact sports, military duty?
No.
Okay. So since he reported no, we can go straight to step 4. So we'll just do a few of these because you can already see the rating form where he said no. So for step 4, I'm going to ask you about any other illness or medical problem you have had. Have you ever been told that you've had a stroke or bleeding in your brain? Other words you may have heard include ruptured aneurysm or infarct. No. Okay. So you guys can see how fast this form can go, even if someone does report a significant injury. One other thing to note, if you compare his rating form to the scoring guidelines, you can see that Mr. Doe likely sustained a mild TBI with loss of consciousness. Yep. Okay. And then we have one more case example for you.
Okay, and we'll try to make this quick. We realize we're getting there to our time limit. So Ms. Doe is a little bit more of a complicated case. She's a 42-year-old female. She reports a history of multiple brain injuries, her first injury occurring at 8 years old. As I interviewed her, her primary complaints were a long history of psychiatric issues, including anger outbursts and suicide attempts. She has lots of short-term memory problems and poor social relationships. She did obtain her associate's degree in 2011, but her work history is very unstable.
Okay, so if you look at Ms. Doe's rating form, you can see that when asking, do you want me to ask you the question?
No, go ahead.
You can see when we asked the first question, she reported yes. So she had been treated in an emergency room following an injury. And when we asked for the cause, she told us that she was hit by a car. So we recorded that in step 1. And then in step 2, we asked if she was ever injured in a car accident. So she reported yes on that. So you can see some of the questions may give you the same response. Okay, so a lot of motor vehicle accidents will result in hospitalization or emergency room treatment. So the same incident may trigger a yes response for multiple questions, and that's okay. You can mark yes for those questions, but only report it one time in the table because you don't need additional information. Because if you think back to the scoring, we're only scoring the worst injury or the most severe injury. Okay, so then you can also see when we got to step 2, we asked information about loss of consciousness. For one of the injuries, the motor vehicle accident on line 2, she did report no loss of consciousness, so we did ask whether she was dazed or experienced a memory gap, and she indicated yes. So you can see that item, that time we answered that because she had reported no loss of consciousness. And then again, when we got to step 3, she did report no repeated injuries, so we went straight to step 4. When we asked about the very first question, have you ever been told that you've had a stroke or bleeding in your brain? She did indicate that she had an aneurysm, so then we did ask an additional question. We asked her if it did rupture, or did she receive any further medical treatment for that, and she indicated no. So we did mark that one no, and then the rest of the items were fairly straightforward. So if you were to score Miss Doe's rating form, what's my note here? Sorry. If you look at her most severe injury, you'll notice that her most severe was the first line when she was 8 years old and she was hit by the car.
And her loss of consciousness is greater than 24.
Greater than 24 hours, so that would score her in the severe TBI range.
Okay. So that is our very brief overview of ABI and how to screen for TBI and ABI. Again, just to reiterate, we are hoping that this measure will be helpful for you if you feel like you're having question about whether or not the person has had a brain injury. Certainly, we're not saying that anybody has to use this. This is only to help you if you feel like it would be helpful. and also is not required in order to make a referral for resource facilitation. We have had several times in the past, and certainly welcome in the future, that if at any time you have a question about a particular case and whether or not they may qualify as having had a brain injury or they're an appropriate referral for our program, you just shoot it our way. Usually a lot of the questions come to our program manager, Laura Trexler, and then she will forward them on to one of the neuropsychologists, myself, Dr. Trexler, Dr. Haskins, to help further delineate that. I know it's 3:25 by our clock, so if anyone has any questions, we're more than happy to stay and answer any questions. I don't see anyone typing. Maybe we could just give them until 3:30 if they send questions. Sure, yeah.
Oh. Okay, someone's typing.
Looks like we have multiple people typing, but I don't have a question yet, so I'll just we'll take them as they come. Okay, Lisa Brown says, I did not receive a copy of the OSU. Could you email a copy to us? Yes, so I'm not exactly sure how this was going to be distributed. We apologize. We were making some last-minute edits, honestly, even this morning. And so it was sent, I believe, to VR leadership, and then hopefully will be disseminated very shortly to you if you have not already received it. Lisa says, is this slideshow available for us to print or have after this seminar? I honestly don't know where this goes. I am more than happy for anybody to have access to it. If you would send an email, if you don't mind, an email reminder, Lisa, to our program manager, Laura Trexler, we will be sure to get that disseminated.
I know they're recording it as well.
Okay, Devin said that she believes this is being recorded and should be accessible in the future as well. But I understand that's separate than having a printed copy, so sure. Shell has asked, are you anticipating that the VRC would do the instrument with our clients? Certainly, if you feel comfortable doing so. You're not required to do that. If you feel like this would be helpful for you, or you just want to try it out, we certainly encourage you to do this.
Yeah, and I know that some other counselors had approached us asking for ways to screen some of the clients. They weren't sure if they had a brain injury, but they suspected it. So this is a tool that you can kind of have in your back pocket as well, that you can kind of quickly go through and assess those clients who are kind of on the edge that you're not sure about as well. So we have it both. We have a PDF file, and then we also have an Excel file that you can edit and collect data if you want to do it kind of in a more systematic way, either way, but we can get that to you. I think that the goal was to disseminate it prior to the presentation, so I know it's on its way out, but yeah, we'll get a copy out as soon as we can.
Any other questions? Not sure.
Yeah,
I'm guessing maybe
not for us.
To the rest of the group, wondering if a prompt could be added to the IRIS Med checklist. Good point. we can also pass along that suggestion has been made when we do have some interaction with like Perry or Teresa. Shell has asked, have you, and it looks like experienced, a loss of consciousness in relation to a head injury? Would that be a good prompt?
Wondering if a prompt could be added to that.
Right. That is a common, I think, fallback first line question that certainly is going to at least get your foot in the door as to discussing possible brain injury. So I don't think that's a bad idea. Keeping in mind that not all brain injuries will involve a loss of consciousness, but certainly that's a good indicator. Go ahead.
So Bloomington, I see you asked, do we take the age of the first injury into consideration when scoring? For the scoring we've provided, that's just one of the ways you can score this measure. They do have several different scoring methods based on what information you want to gather from the tool. So one of the additional scoring measures that we didn't talk about does take age of first injury into account, and I think that is the actual value. It's just taking into account the age of the first injury, and you report that. But it doesn't actually weigh in with the severity scoring that we've provided. Any other questions? Don't think anyone's typing.
Of course, if you have a question, a follow-up question, we're more than happy to address those email or even in a phone call. If it is in direct relation to using the measure, scoring the measure, I might give that to Devin primarily as your point person. If it's more related to just general questions about acquired brain injury, would this person qualify? I don't know. This injury seems a little vague, or those types of things. I'm more than happy to help. Okay, we haven't seen anybody typing for the last few minutes, so I'm thinking we're probably done here for the day. Again, thank you so much for everybody's attention and for your good questions and participation. And again, just let us know if you need anything.